that we see around us. And so we thank you for this. We ask now that you would be with us, give us open minds and porous hearts that we can take in what we are to share and discuss that may enrich our lives and help us to share and enrich those around us. In Jesus' name I pray, amen. Okay.
Amen.
So I wanted to quickly go through some stats very quickly. In usual, we talk about some trends and stuff in the news. And I know there's a lot in the news that you all want to get to, and so we'll cover some of those I've sort of pitched already in questions for sort of an awareness that we can actually make sure we cover a number of things. As usual, I think it's important to just recall that still this is a virus that hangs out around with people who are oftentimes with minimal or no symptoms, oftentimes with prior exposure that they're unaware of, that may go undetected or unnoticed for, on average, 8 days before becoming contagious, and then another week or more before someone might even develop symptoms. And so this sort of contagious symptomatic period or asymptomatic period in total could be on average about a month total. And so we talk about people quarantining for 14 days on average because it takes care of the average lengths of time, but it's not really the most inclusive and safe time if we really wanted to be safe. But that would be sort of maybe extreme hardships. But again, I think it's important to remember we have these sort of wide times of exposure and incubation versus people becoming contagious and or symptomatic. And again, most people are spreading this with minimum or no symptoms. Again, it's spread through what we call droplet or close contact. And we'll talk a little bit about the update to the CDC's guideline yesterday with regard to the language of airborne in a few moments. But in general, the majority of the spread is through close contact and droplet. So it means that if you keep your hands clean, you don't touch your face, you wear a mask, you keep your encounters with unknown sort of status in terms of COVID positive status of people when you're indoors, limited in time and limited in distance, that you should be able to maintain safety. So again, really important to understand the primary mode of spread. When we look at the data in California, I've tracked since one of our first meetings in April 6th all the way to now. This is data as of this afternoon, October 6th at 3 o'clock. You can see we've gone from a paltry 16,000 cases in April to over 830 confirmed cases. Some of this represents testing because we are testing at a really high rate now compared to early on because of the availability of tests. But when we look at just the total number of deaths, we actually do have, quite a number of increased deaths. For our total number of deaths per day, at one point, we were at the peak over 100 deaths in the state in one day. And as you can see now, we're back to sort of like early April numbers of deaths in a day, which is sort of in the about 30 plus or minus deaths in a day across the state of California, which is again a fairly low rate compared to where we were before at the peak. When you look at hospitalizations, again, I think it's important to note that we sort of had this double peak or double hump. The first early hump in early sort of April, middle April, then that sort of went to a steady state. And then we had this sort of late peak that we saw in late July, early August. And again, a lot of this thought due to the reopening or too early of opening of businesses, particularly, and people going back into restaurants and bar with sort of indoor dining and indoor activity. And so what this is really important to think about is how will this look or how will this appear as we go into flu season? I'll talk a little bit more about that. With regard to testing, as I mentioned, I just wanted to show you this. We are now testing each day. Well over 100,000 people across the state are being tested every day. And that's a large number of people being tested every day, which is due to the availability of test kits and test sites, compared to just over a few thousand early in this pandemic a day. So some of our new cases, matter of fact, a lot of our new cases are because we are testing much more. It doesn't necessarily reflect a lot more people who are sick and hospitalized. And this is actually extremely important because we look at what we call the positivity rate of all the tests that are being done. And again, this is one of those things where in the very beginning, we have very limited testing available. And so we're only testing people who we thought had a high risk. And we had almost 1 out of every 2 or 3 people that we tested was positive. Now our test positivity rate is less than 3%, meaning for every 33 to 35 people that we test or so, we will see someone positive. That's still quite significant when you think about the numbers of people, particularly even in LA County with over 10 million people and across our very busy state. So ideally, you know that you've really got a handle on this when your percent test positivity is less than 0.5%. Okay, so we still have a ways to go. Governor Newsom's new plan for reopening really talks now about risk level, meaning that if you have more than 7 new cases per 100,000 or more than an 8% positive test rate, it's considered widespread. We still have a positive test rate across the state that's considered moderate if you look at the numbers I just showed you. But when you think about just how many new people are per 100,000 have cases, this is just partial data from the county ranking. And you can see the highest ranking is actually in the rural areas like Kings County, Shasta, Imperial County. These are high agricultural areas and rural counties. And you can see that they're so far above this sort of 7 or 8 per 100,000 limit. You can see Los Angeles County is here, and we're at 64 per 100,000. Okay, San Diego County, 58 per 100,000. And so San Bernardino, 90 per 100,000. These, of course, are well above, right, the governor's definition of county risk level. And so we are still considered high risk or widespread infection. And therefore, this is why we have still so many restrictions on what is open. If you're curious about a particular county, particularly if you're going to go visit someone, or even LA County and the types of activities, you can go to the California Department of Public Health website. You can type in your county, and this is an example on the right here. It's just an example of the actual web page. So I typed in LA County, and since I knew I had some people who might be interested in nail salons, I typed in nail salons. And then you just say get status, and it will tell you that Los Angeles County as a whole is still very widespread. And under that, that means it has very limited operations of non-essential businesses. And so for nail salons, you can see they can open indoors with significant modifications. Those modifications are listed if you click on more detail, right? Some of those modifications are so cumbersome that they can't meet the public health requirements and therefore remain closed. But actually, nail salons can open if they meet strict requirements. And so you'll see in some places their nail salons are doing nails outside. They're doing some very interesting things. And again, because we're in Southern California with weather permitting, we can do a lot of things. But this is just information that's available for you on the California Department of Public Health website, where you can check different areas where you may visit, how they are doing in terms of COVID activity, and then you can also look at very specific activities. Interestingly, if you type in church, churches are not even on the list. So it's just interesting that it's not necessarily a complete list because churches are clearly listed on the Los Angeles County Department of Public Health website. All right, so with those introductory comments, there are a few questions that have come up. And the first is something that's related to an article that was published over the weekend in the Journal of American Medical Association, or JAMA. And it asked the question, okay, we're getting close to vaccines, maybe. Although there's a lot of conflicting news about that, as we talked about last time. Politically speaking, people say we're weeks away from a vaccine, but when you hear experts, they'll say we may not even have a vaccine available until next spring or summer. Nonetheless, whenever it does happen, it's unlikely that we're going to have so much vaccine available that everyone will be able to get it. And so they will have to prioritize. And there was actually a nice survey that was done across health agencies to look at plans for prioritization of a vaccine. So people are already making these plans, and they started making these plans back in the spring, in April. And what you have here is an example of the prioritization. On each bar graph going from left to right, you have high priority proportion, weighted sort of priority for what's high, what's medium, and low. And then you have on the left column here, based on the rank of highest priority to lowest priority, the list. So the highest priority will be frontline medical care staff working with patients with coronavirus. Okay, that's the highest level, highest priority for limited vaccine distribution. The next will be children with their life ahead of them who have serious illness or risk for actually dying or complications from coronavirus. The next will be elderly or older individuals with 65 years and older who have risk or complications. And then you have everyone between 18 and 65, right? So the youngest first, then the oldest, and then the sort of middle age group, if you will. Behind all of that are the essential workers who are public facing, right? And who many of the people in our communities represent. Okay, if they're otherwise healthy, but they're going out and they're working and they have to confront the public who may or may not be infected, they're actually down the totem pole with regard to vaccination. Okay, and then you can see otherwise healthy pregnant women, children and adults who otherwise don't have high complications round out the bottom of this. So this is what has preliminarily been sort of talked about and what's been drafted in guidelines about vaccine allocation when the COVID-19 vaccine is available. So I'll pause there and ask, do people have questions about that?
In the vaccinations that they've prepared or are testing, are there some that are more higher on the scale of effectiveness, or lower, or just what is that about?
Yeah, so
Some
that's
better
good.
than others. Yeah.
Yeah, so that's a good question, because as we talked about last time, there are, more than 134 active vaccination trials going on right now, not to mention another 200 or so in early phases of sort of development and design. So we talked about last time that there are fundamentally broad categories of vaccine types, right? Vaccine types that actually just sort of deliver protein material, actual protein material, vaccines that are developing that manipulate the virus's DNA and somehow shape or put that into you. And then unpopular, obviously, are vaccines that put modified actual virus right into you. It turns out that we usually or typically believe that the most, or I should say, the vaccines with the closest representation to what you might actually get exposed to, meaning live virus, are usually the most effective. But that comes with potential consequence, right? As well as the perceptions of people saying, I don't want any live virus. That's like with the flu shot in the past. We used to give people live attenuated virus. We don't do that anymore, but that was a really big, I think, public awareness problem with regard to accepting vaccines. And so even if a live attenuated virus might be the most effective, people aren't pursuing that because they, as aggressively, because we know that people's acceptance, the general public's acceptance of that's fairly low. Other than that, when you look at the other sorts of broad categories, let me give some protein, let me do some manipulation, etc. We don't have enough data yet because we don't have enough data back on enough patients to say which one is more effective or not. What we do know so far is that they seem to be so far plus or minus the same. And in vaccine research, plus or minus the same means within probably 10% of each other, right? So that's within error. So it's not like we have one trial or one group of vaccines that came back 90% effective so far, and another one that's only 40% effective. We don't have any gaps like that so far. Everything looks like it's around the 50, or I'm sorry, the high 40s to 60% range, which at this early phase of data collecting, that's about all the same. So a long way of saying, right now, all of the vaccination trial preliminary data looks like, regardless of what type you might get, they all are about the same with regard to effectiveness if all the ifs are taken care of, meaning people are compliant, the vaccine itself is durable and taken care of. Remember, I talked to you about vaccines having to be transmitted in, -0, right? Freezers and stored, some of them stored in -112 degrees, and all of these sort of things that make the vaccine volatile, as well as people having to get repeat inoculation a month later, right? So there are a variety of things that are in the ifs that would have to occur in the real world outside of a controlled study setting to really compare effectiveness. But for right now, they're plus or minus the same.
I have two questions, Dr. Harrington. One
Yeah.
is there any talk of making it mandatory?
Yeah, there's been talk of that in individual states. That's already gone to preliminary discussions in the state Supreme Court. It hasn't gone to federal Supreme Court because the federal government has not been a party to that conversation about mandating anything. It's just been some individual states. I think I showed you guys 2 times ago something from North Carolina, right? That people were trying to pass legislation to make it, to give the health agency authority to mandate it. And that already was sort of struck down, if you will, or delayed in voting in North Carolina because of a public outcry. So, yes, there are some states, California not being one of them, there are some states that are actually trying to push a mandated vaccination, just like they did with, believe it or not, with flu vaccine, right? So, you all know that there are legislation, there are laws in certain states that require certain people, certain personnel to get flu vaccine, like healthcare workers have to have the flu vaccine, or there must be a process of documented declination, right? But that does not apply to the general public. The general public is not required to get the flu vaccine. This would actually be a step above that by mandating that not just healthcare workers and other at-risk people get it, but that everyone in the general public get it. And the problem with doing that, David, is that we don't even have enough vaccine even projected to be produced to make it mandatory for everybody. So the practical applications of even the recommendation of mandatory vaccination doesn't work because we won't even have enough vaccine for every person, if that makes sense.
Next one I have is I read an article, I believe it was yesterday, where it said that I don't know if it's the CDC or another organization, when they were doing the protocol for approving the flu vaccine, the White House vetoed it or didn't allow it to go into effect. The coronavirus, yeah.
Yeah, so there's been a lot of hemming and hawing, going back and forth about CDC's stance on the vaccine and pushing that, as well as the White House miscommunicating about the vaccine. Probably the best way to think about the vaccine is to look at FDA.gov. So the FDA has on its website a listing of every trial that's at least approved by the US or a shared FDA partner for vaccine research. That's for human trials. They have all of them listed. And they also list and update monthly, maybe a little bit quicker for COVID, but update the data and the preliminary information for the trials that are at least in phase 3. And so you can look at that FDA.gov and see a lot of the information. People and the news and the politics, particularly since we're a month away from election, are talking a lot about stuff that, including the CDC, by the way, that's not necessarily accurate or something that's imminent. What you really need to look at is the FDA site, and you can listen to people who are sort of nonpartisan. The CDC is a governmental agency, and it is partisan, unfortunately. But a nonpartisan source of scientists who talk about vaccine, and look at those articles. Like you can look at an article in Science, you can look at an article in Nature, and these articles actually have done a really nice job describing not only the vaccine, but the likely timeline of a real vaccine coming to fruition and to the public market. And so there is no way there's any vaccine that's going to be available or being blocked from being available. It's just not even near ready in the next few weeks. We're looking at the earliest, probably, like late winter, early spring, if you really want to talk about a vaccine going through all of the safety, all the efficacy, all the proper channels, and being approved by the FDA. So a lot of that sort of conversation and articles are noise, or sort of related to the political process that we currently are immersed in. And I wouldn't pay a lot of attention to that. If you want to, you can go to the FDA.gov and they'll give you an update, a real update on what's going on with the vaccine trials. Okay. Any other questions about the vaccine or vaccines as a plural? All right, the next question.
I have a question. Let me unmute you. Hello, Dr. Harrington. So I have a question because I heard there's so many vaccines out there. How are they going to know which one to approve when there's so many competing vaccines?
Same way they do with every other drug, it's the same way they do with other drugs, and it's not necessarily transparent or fair, right? So what I will tell you, it doesn't matter. We're not just talking about vaccine. If I gave you diabetic medication or hypertension medication, do you know how much of that medication gets approved versus doesn't get approved? Only a minority of medications get approved. And some of that actually is transparently available in terms of the FDA protocol. But there's a lot of stuff that goes into decision-making about what gets approved or doesn't get approved that is not transparent to the public. And I wish I could tell you what goes on, in the closet of the FDA, but no one really knows except for them. Some of it's political, some of it's political/financial. Even though it's a governmental agency, they have lobbyists that have special interest group in biopharma that actually, unfortunately, has conflict of interest in decision-making. And so there's no straight answer to that. Unfortunately, the approval process for drugs is neither equitable or fair or transparent in this country. That's why you have some drugs approved ahead of other drugs. That's why you have drugs that have no business being approved, meaning that they don't even work, but they're approved, right? Or you have a new drug, like why do you have, for example, this is germane to your question about vaccines, why would you have 14 drugs for hypertension that work exactly the same mechanism, okay, and have no difference in side effect profiles and no difference in delivery, no difference at all, which would actually make one more competitive than the other? Why would you approve 14 of those drugs for consumers to be confused about, doctors to be confused about, people to compete in the market, right? Why would you responsibly do that? It has nothing to do with what's in the best interest of the patient, right? And so these vaccines, just like the flu vaccine, these vaccines are actually not made by the government. They're made by private biopharma companies and they will be doing what they usually do at the end of the day, trying to optimize their return on investment and their revenue or income. And so all of that decision making, unfortunately, is not perfectly um, uh, transparent to the public, and it is very likely that they will um, approve whatever comes first that's reasonably safe and has some reasonably efficacious data. And remember, all you need to do is be efficacious 50% of the time and you'll get approved, okay? It doesn't have to work 90% of the time, just 50% of the time for a vaccine, and that's fine, okay? That's our flu vaccine for you. And then what will happen is you'll have one company after another company submitting to the FDA, and the FDA will approve or not approve based on, as I said, these sort of non-transparent sort of rules. So I can't answer that question any more, sort of clear than that, unfortunately.
No, that's fine. Thank you.
Yep. It's the world we live in U.S. medication, unfortunately. All right. Let me move to the next question, which is probably applicable to some of you, or some of you may have been thinking about it. Is it safe to fly during the pandemic? And I don't mean fly off of a building or fly in your backyard. I mean air travel, right? With in an airplane. And what precautions, if any, should you take? And again, there's a really lovely article that was published for consumers this weekend in October that actually reviewed the sort of safety precautions in the airline or air travel industry as it relates to COVID-19. And I put up this slide because I think it's actually very helpful as an accessory to sort of the explanation. In general and in summary, most experts will tell you that air travel in the era of COVID-19 is safer than you going shopping at Trader Joe's. Okay. Now, why is that? Well, even in a plane that might be full with people who are on either side of you, the most important thing is the air exchange rate. Now, the air exchange rate in an airplane is anywhere, depending on which building you're in, including a store, anywhere between 4 at the lowest to 15 times the volume of air exchange rate than any building you might be in, okay, on the ground. So airflow in an airplane is much higher, and not just flow, but exchange, completely exchanging the air is much more efficient, and there's much more volume of air being exchanged in an airplane than in any public building or building that you might be in. Okay, that's number one. Number two, half of the air that's in an airplane comes from outside. So it's actually fresh air coming in through inlets, okay, at 30,000 feet or 40,000 feet. There's no COVID up there, okay? And that's mixed in with half the air that's being recirculated from inside the plane through HEPA filters. These HEPA filters, HEPA filters, are the same filters that are used in infectious prevention control for hospitals. So in a hospital, like in the ICU, that they're trying to make sure that the air circulation in an isolation room in an ICU is safe. Those same sort of filter or filtration systems are used in commercial airlines. So the air in an airplane is better than any air that you might have in the highest level of recirculation and ultrafiltration of air on land in a building, in your house, in a public building, in a store, you name it. Because half of the air not only goes through the circulation, high quality circulation, recirculation, but the other half comes in as pure uninfected air from outside at 30,000 plus feet. Okay, so So just the air. Now, the other part about the air is where the air travels. If you're sitting in a row, say row 15, we're going to give you sort of economy plus, okay? If you're sitting in row 15, the air that you breathe is coming from row 15. It's not going to come from row 20 or from row 5. Well, you wouldn't come from row 5 because that's first class, and well, they breathe a different type of air. But you understand what I'm saying, right? So the air that you're likely to breathe is going to be the air that comes directly from your area. And that area exchange is occurring very rapidly, very, very rapidly. All right. So the chances that if there was someone 3 rows behind you who was infected and they were breathing out and some of that was coming outside of their mask, that would somehow circulate up to you on the airplane is next to 0 compared to someone on the next aisle at Trader Joe's breathing and that getting to you on the next aisle. Okay? So air travel from an air circulation standpoint of view is extremely safe. If you think about the number of people who have traveled in the last 6 months even, still millions of people, millions and millions of people have traveled. There have only been to date that we are aware of 43 people that we believe, and I say we believe because that's the best guess we have about source tracing or contact, 43 people who've been positive, and we think the source was air travel. 43 out of millions and millions. There is no other sort of environment other than just being outdoors 100% of the time, but for transportation, where the risk is that low. Okay? Now, what can people do? As I mentioned, it's safer than many of the other things you are doing already. They obviously trained the staff. People actually have PPE, etc., to minimize transmission from a airline personnel to a passenger. Obviously, there are sort of public service information and communication when you book a flight, as well as in airports about traveling when you're sick. And there are some airports that are outfitted with your ability to even be tested ahead of time if you like. It's not required, but it's optional. You can take the airflow that's oftentimes above you, and the recommendation is to point that directly down at your head. And that will actually, again, push air away from your face, push air away from you breathing it. Once seated, stay seated if you can. So go to the bathroom before you get on your long haul flight, or just hold it. Sanitize the area, obviously, before you sit down, and try not to touch your face, really important. And keep your mask on at all times. And if you have to drink or snack, do it very quickly. But try not to have any long meals or snacks in planes that you might prepare yourself, as many planes have stopped serving meals anyway. All right. Any questions about airline travel? Want to be sure I still have you. We're still okay. Everyone still with me? I need to hear something just to be sure.
Yes.
Yes.
That's excellent. Thank
Okay.
Yes.
No, that's good. All right, this is good. I just need to hear something because I'm in a screen where I can't tell.
It's okay.
All right,
I
now.
feel great because I'm going to be traveling on a plane. So thank you.
Yeah, I traveled not too long ago and everything was fine. Okay. Let's see. So David, I think earlier you referenced CDC updates, and there was an update yesterday regarding the term airborne and SARS-CoV-2 or coronavirus 19. And the question that's been sort of talked about in the news is, well, what does it mean? Are we now saying that it is airborne when before people said it's not airborne? And if you guys remember, I told you that transmission occurs along a continuum. right? There's some stuff that just requires you to pick up a gob of it and slap it on, right, a person, or some of it just requires you to just eat it. You know, you really need that direct contact with the contaminant or the particle. And then there are things that are you just blink and you're infected, like measles. Okay, so there's a continuum of this, and there's really nothing black or white. So they did update their guidelines to include language that actually says that SARS-CoV-2 can occur via airborne transmission under special circumstances. And what I did here is I provided you the 3 circumstances that are listed in their updated sort of statement and guideline. And basically, it says first that it's uncommon and typically only occurs with prolonged exposure in an enclosed space with someone who's infected. So that's really important, right? So no one was really saying airborne is impossible, but the idea that I'm walking down the street, okay, and someone walks by me, and a good breeze or so just gave it to me. Now I have COVID because of that transient outdoor connection. No, that's not happening. Remember, we talked about the D's, right? Duration, density, and distance. And that's what this talks about. So you need to be in an enclosed space with someone who's infectious, okay? And or in that same space after someone who's infected left that space. But then you need to actually have the space, the duration. So again, you need to kind of be in that space or be around those individuals or in that space that's poorly ventilated and closed for a prolonged period of time, right? And it's inadequately ventilated, which actually keeps the air dense. All of that has to happen to give you a chance. It doesn't guarantee, but to give you a chance of airborne, right? Because even in those circumstances, still the most common is going to be close proximity droplet, touching, or someone directly sneezing, etc. Okay, so don't get it wrong. Even though they updated the guidelines, all they're doing is clarifying the uncommon circumstances where it might be a risk. And this is consistent with what we've talked about the entire time. If you follow the 3 Ds, you're safe. And keep a mask on, right? So I don't know you, guess what? I'm not gonna be talking to you face to face or within 6 feet for 15, 20, 30, 40 minutes. I'm just not gonna do it, okay? I don't need to talk to you that long. It's nothing that important. Give me a call, right? Particularly if it's inside. So that's what we talked about the whole time. You use the 3 Ds and you wear a mask. And even importantly, if you have to be in an at-risk, really closed area like at work, we talked about this before, you may even consider keeping your eyes covered. So these are these face shields or at least wearing glasses, etc. Okay, so this is, I think, a really important update, but I think it's already been misconstrued in the media. Again, this is an election year, particularly as it relates to the recent issues with 45. People are conflating what happened at his press conference before going into the hospital and using the CDC sort of communication to add fuel to that. And that's unfortunate because it's very misleading. So let me pause there before I get to the last popular news item and ask if people have questions about the technical possibilities of airborne transmission of COVID.
I think everybody's okay.
Man, this is good. I guess I'm speaking with such clarity. All right, now, the last group of questions, I'm sure people want to talk about our hashtag 45 president and his COVID-19 infection. I am not going to render my personal political views on this, but I am happy to take a moment or two to answer curious questions from a medical professional perspective, non-media biased, if you have questions about this breaking news of our current president.
I got dozens of them, but I'll just start off with one and give other people a chance to answer their questions. But one was that they were treating them with 2 experimental treatments. How wise is it to get 2 experimental treatments?
Doesn't matter. So this is easy. Like, again, I'm embarrassed to say that our media has done nothing but treat this in a completely nonsensical, politically biased way. Okay. And what I mean by that, if you were, forget that it's Donald Trump, forget that people may or may not like him, forget all that, and make this COVID-19 and Obama, okay, who was during his first term for sure, had the highest rating, popular rating of a president in the history of the United States since we've been measuring that, okay? So let's just say it was Obama and he tested positive. What would you want done for the most popular president, the most influential world leader, right? What would you want done? You would want everything potentially possibly done in the kitchen sink to save his life or prevent a complication, even if it's experimental. Weighing
Right.
risk and benefit of safety, right, versus efficacy. So if this was Obama and we had our same politically biased media of CNN, who's very much so, biased towards a certain party, I guarantee you we wouldn't be having this conversation. Okay, this would simply be opening up whatever we can do to prevent any further complications or death to one of the world's most important leaders. Okay, that's just, no one would question it. No one would say, well, why are we doing experimental drugs for the president and not giving it to the common man or woman? Well, because the common man or woman doesn't have the power, authority, responsibility. That's why, right? And I'm telling you this, non-biased, nonpartisan. The current president is not someone I voted for or someone I will vote for, okay? And not my favorite person on earth. But taking that away, if we're just being practical about what people would do in any country, not just the US, in any country, if your world leader or someone important got sick, you would actually open up the entire medicine cabinet and use whatever you could to, even if it's not 100% proven or whatever, to try and mitigate or minimize any complications. That's what anyone would want, and that's what anyone would do, and that's what they did. And that should be the end of the conversation. Unfortunately, they're politicizing that, and people are kind of buying into that rhetoric. I hope that makes sense.
Yes, very much so.
Right? So any other conversation than that is a political one, is one that's actually trying to emotionalize this in the setting of an election. Okay.
Well, is contact tracing, is that political too?
Okay, well, let's make sure we're dealing with the treatment piece. Any other questions about treatment? Now, I can talk about one experimental treatment versus another one. Some are actually closer to being proven versus others, but to me, it doesn't matter. If I were the doctor of the president, I would look at all of the therapies that are available, and I would look at risk benefit, and I would start exposing him to whatever I could that had, I thought, the marginal benefit over risk. Okay? Because no one wants to say No one wants to say, if he has complication, I should have done this. Okay. All right. If there are no questions about treatment, let's just move on to contact tracing.
I still have a question about this treatment then. Because
What's that?
he hasn't technically finished his treatment yet, has he?
No, he has not technically finished it, but that doesn't mean that even if he had finished it, doesn't mean he would not be contagious. So that's a separate question, right? There are two questions that are sort of right here in front of us. One is contact tracing. The other is his ongoing risk of being contagious. Okay, so the easy one to dispose of first is ongoing risk of being contagious. It's still there as far as we know. And I say far as we know because we don't know when he was actually first infected, right? We still don't have that publicly transmitted. All political, all BS. People aren't being transparent about. Like he could have tested positive or tested negative 3 weeks ago for the last time, and therefore been positive for the last 2.5 weeks. We don't know any of that. So we have to assume that for right now, we take day one, right, as the day that he was positive, and we can back up maybe no more than 5 to 7 days because he had symptoms. And then you take that as day 0 and you point forward a month, 30 days, if you're going to be conservative, meaning that this is during the time that he still has some risk of being contagious to other people. So that doesn't mean that you put him in a box around nobody else. That means that everyone around him must use PPE, he must use PPE, and you minimize unnecessary exposure to the general public. That's what should happen.
Okay, also, I know the media kept going about, they weren't telling about his what he has and all this other stuff. And I'm thinking HIPAA, the physicians cannot do that stuff. I'm like, they can only say so much because of HIPAA.
No, HIPAA doesn't apply to the president. So that's a very good question. HIPAA to a degree does not apply to someone in public office. And so there are some details of the medical record which are protected, but general condition, status, diagnosis, treatments, etc., which are generally protected by HIPAA for you and me, is not protected for by the president. It's not. And so they literally are withholding information, but I will only tell you that every president who has been sick, they've withheld information. Every president who's been
They have
sick.
to do that for security, et cetera, right? So they have to do that for the whatever you call it.
No. That has nothing to do with security. That's really more about withholding information is really more about their perception of compromise of the public trust. It's not. It has nothing to do with anything else. And this is not a new thing for Donald Trump. They've done this with everybody.
Right.
Everybody who has been sick, who's caught a cold, who's had a stroke, you name it. It doesn't matter. You can go back to FDR. They have absolutely withheld the details and information. And it's not HIPAA. It's all political.
Right.
Okay. So that's again, that conversation is a political one because we're in an election. It has nothing to do with the truth or reality. Okay. But people, regardless of parties, have done this, and they will manage the public perception because, as you all know, the president is a public personality, and you're managing that. So let me go to the question, and I think it was Andy or Andrea who raised about contact tracing real quick.
Yeah.
And if the question is is contact tracing being done appropriately? Is it legitimate? Is it responsible, etc.? I think it's a very interesting thing. Like if you talk about the conversation about contact tracing around the president, again, that conversation is completely political. I mean, everyone knows who the president is, and everyone knows if they've been around the president, So it's not a secret. You don't have to do contact tracing around the president. So, for example, if you're at a rally, you know you're at the rally. Or if you weren't at a rally, you know if the next person was at a rally, right? So at least 2 degrees of separation that related to the president is already known. And what you would do with that information is 2 things. The first, which is generally recommended for everybody, is quarantine yourself for 14 days, period. The second is if you develop symptoms of any sort or any question, get tested. That's it. And that's what you would actually do for everybody. That's what's recommended by the CDC, by the California Department of Public Health. We do not actually have resources to do detailed contact tracing. Even someone has their mic on, I'm getting an echo, but even at that high level, they only have resources to do contact tracing so far. Because remember, the degrees of separation expand exponentially. So you take the press conference, right? You look at the 50 or 60 people who were there. All of them, intermingle with each other, but then they go back to wherever they go back to. They go back to Congress or the Senate. They go back to the universities. They go back to their homes. They go back to whatever. And then those individuals go back to wherever they go to, right? So on and so on and so on. There is no resource large enough to do the type of contact tracing that the media is making you think should be done. There's no resource available to actually do it. It's not possible. So the contact tracing that is appropriately done is one of informational, meaning that you take immediate contacts, right? And then everything else is sort of like public awareness, reinforcing the 2 things I talked about. If you believe, that means even if you have a hint or a question that you may have been in contact directly or indirectly with the president or anyone around the president, directly or indirectly, and you believe you meet the criteria for significant contact, which is more than 15 minutes, less than 6 feet, proximity, blah, 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 particularly indoors, then you should self-quarantine for 14 days. If you have no symptoms over 14 days, come out wherever you are, you're okay. If you have symptoms, then get tested. That's the simple message around contact tracing, which is consistent with the CDC guidelines, consistent with every public health agency, and which has been blown out, again, out of proportion for political purposes on CNN, MSNBC, and other places, the like. Again, to demonize him for political purposes, right? He's irresponsible. He does yeah, probably it was not necessary for him to go in a car and as they describe, hermetically sealed car, with 4 agents in the car and go driving down the street for a photo op, okay, while he was in the hospital. Sure, okay, absolutely. But what I would say about that is that those men and women who surround the president with their lives, Secret Service and the like, get in the car, walk beside him every day with the risk of losing their lives. And so I guarantee you they weren't forced to do that. I guarantee you that was what they would call probably in the line of duty, and that they would individually view that as minimum risk compared to what they usually do on a day-to-day basis, mask or not mask, right? With potential bullets or bombs exploding on or about them. So again, overly politicized for obvious reasons.
You mentioned about the SUV they were in, hermetically sealed. I think I mentioned someone last week, or it couldn't have been last week, but that those SUVs, they're actually sealed for biological warfare. So I'm
Absolutely.
sure they just turn on the filter and it's totally clear.
Yeah. They actually have, and you are right. I've been fortunate to be in those vehicles a few times, and I can tell you that they are outfitted differently than any vehicle that any one of us would have access to, and that particularly the vehicle that the president and the first lady rides in is a tank. It is literally a tank, and can withstand the armory that a tank would get, or better. And the filtration system and the air exchange and all of that is much more rapid, than you would see and experience in a regular car. And to that end, it's very similar, not quite to an airplane, but the sort of risk, again, these are smart people. I think that the doctors and a lot of people are smart. They're, correcting airflow. They're dealing with airflow in the vehicle. And so, again, I think that these are important details that amount really to minimum or much of nothing. But unfortunately, it's being talked about in a way that's sort of, politicizing the circumstance. Other questions about hashtag 45?
Okay.
Uh,
Dr. Harrington, I have a question, non-45 related.
okay, good. I'm glad.
It's more personal. I work with the developmentally delayed, and
Yeah.
we have put things in place in order to make it more safe for us to assist them with the things that the services that we provide for them. And I just
Hmm.
wanted to get your opinion as to whether or not what we are doing is enough, or if there's more that we can do. As far as
Okay.
when we transport them with us, we now have them sit in the rear seat diagonally from us, in
Hmm.
addition to them wearing a mask.
Okay.
Is that satisfactory, or is there more that we can do? In other words, should the windows be rolled down, or does that matter? Or
Yeah. So that's a really, really good question. I think that if you're transporting, it's sort of you can take the question one of two ways, right? One is if you haven't tested the individuals you're transporting, then should you assume that everyone you're transporting is infected, right? Which is what I would do, right? If you haven't tested the person you're transporting, then assume that everyone, I've said this before in other talks, always assume that whoever you're around is infected. If you don't know they've been tested or you don't know about their whereabouts, right? And so if you make that assumption, you're transporting someone that hasn't been tested and you assume that they're infected, then both people wearing masks is super important, right? Keeping as far a distance as possible is super important. Turns out that if you guys are both facing forward, then you minimize your risk just because of the way you're facing, right? It's different than facing each other. The last thing that can be done that's very helpful and has been sort of implemented for most healthcare workers has been wearing a face shield, right? And so many of the face shields are reusable. They kind of wrap around the eyes and the face and give an extra layer of protection for anything that might be entrained when you're inhaling into the mask. And so, even if just used for transport, if there was one additional thing that I would say you could do if you had the resource, is that the personnel who's doing the transport with an undiagnosed or an unknown client or patient should have a face mask on and a face shield on. Okay. The face shields are reusable. You can clean them and reuse them, but I would do both. Not to mention, obviously, disinfecting the car or wiping down the internal parts of the car in between uses.
right. Okay.
Yeah,
Okay. Okay. Thank you so much. I appreciate that.
of course. Now, the face shield has proven to be an additional protective layer for individuals who might have risk for prolonged exposure or prolonged encounters by the nature of their job. And so you'll see if I've gone to outdoor dining, and you'll see a lot of the servers, right? Even though it's outdoor dining, they'll have face shields on. You go to a store, and they're an essential store, and they're open. Say it's actually like I had to get some tires changed on the car, and I went inside. Everyone had face shields on, right, as well as a mask. So there's no question that when you're dealing with the undifferentiated public or client, that to maximally protect yourself includes taking care of your hands and surfaces, and that could mean even wearing gloves, disposable gloves, or at least wiping wiping your hands clean, disinfecting your hands, but wearing a mask and face shield is sort of the maximum way to protect yourself. I would not recommend walking around in public with the face shield on. I think that's overkill by far. But if you're in a work situation where you sort of have no choice to have these sort of prolonged risk exposures in an enclosed area with an undifferentiated person, a face shield with a mask is ideal. All right, I was done with my slides. I see we have more people who've joined us, which is wonderful. A Vina V. Any other questions? I'll take any. Otherwise, we will close up.
Dr. Harrington, I don't know if you saw my question. That was a question somebody gave me to ask you about.
Okay, let me just go here. Okay, yeah, so I'm not sure when you came on. The question is about the virus is airborne. If I spray my office daily with the virus from adjacent rooms or a walkway, flow into my office, be eradicated. Okay, so let's see. This is sort of an interesting way to try to address this. The idea of true airborne means that something in stagnant air could just stay there, right? Circulating for hours and hours and hours. Now, I know you guys have read some reports of this in experimental sort of designs and studies, but for practical purposes, that does not apply to COVID. COVID itself is too large of a particle. It actually comes out humidified, okay, attached to droplets or attached to some, and it will fall to the ground in a very short period of time. Yeah, that people are seeing the air on them. You spritz and say, oh, you can see those particle droplets, which are even larger than COVID, all fall down to the ground. So you're only disinfecting, if you will, potentially disinfecting something for the time. You're only protecting the air for the time, if you will, that two things can happen. One, you can actually see it. Two, or smell it, right? So sometimes you can smell like Lysol, right? But as soon as smell dissipates, it's very ever sort of protection you were getting from that in the air also dissipates. And I would not recommend people walking around with the Lysol can, spraying continuously and testing whether or not they could smell it. And as soon as the smell goes away, spraying again. I would not recommend that. I will tell you again, the chances that anyone will get this from airborne who are walking by or through an airspace transiently in an enclosed room, enclosed office setting, without wearing a mask is low. If you keep your mask on and everyone's wearing a mask, it doesn't just go to low, it goes to zero, okay? So you really are talking about someone in an office setting. It's really this situation. Like for me, I have someone who comes into my office and they're like, I really need to talk to you in person. I say, okay. Now my office is probably 32 feet, 32 by 20 something, like 24 by 30 feet or something like that. So a pretty large office, right? And I have them on one end and I'm still on the other end. And we talk. I might be in there for 30 minutes. I am not worried at all with this person who's wearing a mask and me wearing a mask of being infected. Like I have zero concern about that. There's air exchange and ventilation. It's not perfect, but I'm not worried about that. I would be very worried. Someone came into my office and I had an office that was 10 by 10 and they wanted to meet with me for an hour. I would say, no, let's go for a walk around campus. We're not going to meet in my office for 30 minutes. Okay. So again, the D's: distance, duration, and density are the three things that if you're in an open office atmosphere, um, that takes care of density and that takes care of distance. The duration really is associated with proximity. If someone came up on your desk trying to talk to you, right? That should be hi bye, or just hold on a second. I'll text you, or I'll call you, or we can FaceTime, or we can Teams, or we can Zoom, or let's go outside and talk, right? So I would not worry. I think that is actually overkill. And when we talk about what we know about increased risk of infections and people getting infected with our public health data, we know that in restaurants that were indoor dining and that in bars, when people were in close proximity without a mask, right, for prolonged periods of time, we were transmitting the virus. When we stopped that, no one got infected, right? So that's, again, I think, strong reassurance of the settings that are required for the virus to be transmitted successfully.
Right.
Uh,
I know what you're saying, Dr. Harden. I think it's an overkill because that's one of my coworkers. And because the CDC came out with this idea of it being airborne, she is freaking out. She's going to bring
Yeah,
some Lysol. She's going to pray.
Janice, were you on the line when I talked about that earlier,
Yes,
or no?
yes. I was here from the beginning. Yes.
Yeah, so what I would do is I would, and even rational thought and something in print may not convince her. Do is I would show her. You can just go to cdc.gov news, click, and you'll see the updated guidance, and take her to that and let her read that for itself, because I think the guidance did a very nice job of making it clear that they're not just saying, hey, this is airborne like measles. In fact, they specifically say this is not like measles or tuberculosis. We are not recommending that people alter the recommendations of circulation and proximity and all those other things that have been previously recommended. We're specifically saying you don't need to do anything different. They specifically say that, and then they go on. The only time you should really worry about airborne are in these three circumstances. So if you can mitigate those three circumstances, you don't have to really worry about airborne. Airborne is a non-issue. And that's why this whole airborne conversation around the president in this press conference is kind of crazy, okay? The people who are likely to get it, even there, were the people who were talking for 20 minutes outside, like Christy and others who are like right up on each other, hugging and touching each other for 20 minutes. Okay, that's legit risk. But to say that Chris Christie infected some guy or gal who was 20 feet away, but he never hugged or touched because he was breathing the same air outside, that's a joke. That's not true at all. Like, not possible, right? So I think that I would take her to the site. The site actually, I think, provides a cogent argument for what airborne is and what airborne isn't, and how airborne applies to COVID-19. I think it does it in a really, really nice way. But she still may not be convinced and carry around a Lysol bottle and wants to spray everywhere. The problem with that, to be frank, is that Lysol, for people who might have reactive airway disease or asthma, is injurious to these individuals. And if it were me, I don't have asthma, but I would not want a bunch of Lysol floating in the air continuously. I'd be like, go home, stay home, but don't be spraying Lysol in the air around me. I don't need to breathe. I don't need to breathe this stuff. It is still a chemical, right? Why do I want that in my lungs? That's me personally, right? So I think there's infringement on other people's personal space and rights with the potential concern or paranoia that she might have that also needs to be taken into consideration and could lead to people having some issues. There was a story recently, and people are bizarre in terms of the way they're thinking. There was a story, there was a guy in Washington who went into his but his adult living area, healthy guy. He literally walked by someone else to push the elevator button. That's all. The elevator button wasn't pushed. He pushed the elevator button because it wasn't pushed. And when he pushed the elevator button, the other guy said, 6 feet, dude, and then stabbed him 13 times. 13 times because he was under the 6 feet. So recognize we have to be very careful about enabling and feeding into some of the paranoia, the fear, real fear that people have, and do our best to have some compassion, but also help them better understand. And if they don't, then we have to still be considerate of other people's rights and their well-being as well. So there is another question. Okay, my nephew, I will talk to you afterwards. Okay, no problem. All right, anything else? You guys have been very patient. You guys are the troopers. Yeah.
Just one more thing. There's a comment made by, like you said, #45 that actually partially, in principle, I agree with. I think that the media blown it out of proportion. Where we said, don't be afraid of COVID. Don't let it dominate your life.
Yeah, so I think there are two things. I think, now this isn't a political statement I'm making. I think as a leader, our current leadership has done a really poor job from the beginning of helping people understand the real gravity and breadth of this disease. Okay, there's been a lot of poor communication, poor representation. Even if I've told you guys, like, I don't really believe that wearing a mask in public outside does anything. Do I wear a mask outside when I'm going somewhere or going from my car to Trader Joe's and all sorts of stuff? Absolutely, I put it on. Why? Because I'm also not just managing the real, I'm managing perceptions, I'm managing how I might be received or how someone might actually react to me. I don't need someone stabbing me 13 times, right? So I'm managing my surroundings, right? And so I'm gonna wear a mask. I also want to send a message to people who are mask disbelievers that this is a good thing to do in general, right? So I don't think our current leadership, federal leadership, governmental leadership did that, right? Both in action behavior and in words, right? So neither words nor deeds were helpful to the American populace about staying safe, taking it serious. Now, in that regard, I completely agree. On the flip side of that, I've told you all that I believe that if you choose, it is extremely possible for us to misuse our God-given power. What is our God-given power? One of the most important God-given powers is the choice of where we choose to focus our attention. That's completely up to me. No one else can do that for me. People can put stuff in front of me to distract me or to get me to look or to get me to smell or to taste or to listen, whatever it is. But I control my focus. And so this notion about putting too much focus on COVID in our personal lives, I think is a really wise statement, even if it misrepresents the intention of the president or anyone else who might be, for that matter, a lunatic or manipulating. But I do think the notion that we put this in the context of our life and well-being is really important. So, Janice, you talked about a coworker who's so paranoid they're walking around with Lysol and they're asking all these questions. That person is being more traumatized by the fear, right, and anxiety that they're living with moment to moment than the virus itself. Okay. And I would say that that's not just the virus, right? That's just not like COVID-19. What I'm talking about, and Vina, behavioral health expert, she'll tell you, I think she would agree that this is not just COVID-19. It could be anything that people get obsessed with and choose to focus their attention on that just causes stress. So stress and worry, right, is taking responsibility for things that God has intended you not to take responsibility for. That's what my mom used to say, right? So worry is taking responsibility for those things for which God never intended you to. And so if we are, again, faithful believers, God is telling us that we actually control our attention away from these sorts of things so that we can live a more fulfilled, faithful life. Whether it's COVID-19, whether it's the frickin' election propaganda stuff, whatever it may be. Doesn't mean that we're not informed, doesn't mean that we're not aware, but there's a point after which there are truly diminishing returns and it's harmful. And so, yeah, I believe that when you think about COVID-19, I'll give you even a more pertinent example. In our hospitals right now, we have the lowest amount of patients who have COVID-19 in our hospitals currently than we've had since the beginning of this whole thing. Okay? Like the lowest amount of patients in the hospital right now than we've had since the first 2 weeks of this infection. That's pretty impressive. Now, I can still spend my days talking about COVID, even though in my hospital with hundreds and hundreds of patients, I have 12 people in the hospital who have COVID. 12, that's it. 2 people in the ICU, 12 people total in the hospital, a fraction of everybody else. And if I don't actually wake up and start talking about what I can do for the other 95% of people in the hospital who are there sick, if I don't pay attention to that, I'm doing a disservice, right? I'm allowing myself to focus and pay attention to something that, albeit important, should not be the driver. It may become the driver in the fall or winter if it spikes up again, but now it's not the driver. I'm aware, I'm taking care of it, but I'm also focused on things that are more vital and important. And I would say the same thing for our own health and well-being as individuals in our own tempo, that we have to sort of do the same thing. I think you guys are all super well informed. You're super bright, smart. You participate in these conversations. You've asked great questions. I think we actually are on the same page about what this really is, about what your real risk is. You can actually take that, control that, manage that, use that to put things in the right perspective and then move forward, right? And not stay stuck.
Thank
So
you.
Daryl, can I add this then, since you said
Yeah,
about
go
my
ahead, B.
behavioral express? Is
Yeah.
that something that I've been working with some people on, is helping them to understand the old adage that pain is inevitable, suffering is choice. And if we
Right.
look at our fears as the way we manage fear is by recognizing those things by which we can't control. Coronavirus, Rona won't be the only virus that the world ever deals with again. But there are things that are within our control that can actually, by just doing those simple things, can reduce our stress. So now I recognize that yes, I may come in contact with this virus. I may not. There are things I can do, but traumatizing myself would then become my choice. If I choose to continuously either isolate myself or live in a space of fear, that is not something the media or anybody else imposes upon us. That is a choice we make. And I
Mhm.
think that when we can look at life that way, I can wash my hands, wear my mask, socially distance, and I'm probably gonna be okay.
No, not
As
probably.
opposed to just,
Not
yeah, I'm
probably.
gonna be okay, as
Yeah.
opposed to sitting shiva somewhere in fear that this is gonna happen, it's gonna happen, it's gonna happen.
Yeah.
Pain, yes, pain happens. Suffering is a choice. And it's the
Yeah.
same way with the virus.
Yeah, I think I appreciate those words. I think you're, spot on, Vina, and and I know you're a Viktor Frankl disciple. And I completely subscribe to this logotherapy sort of approach, if you will, to um, our experience to a large degree, meaning that we do have control over it. I do think, and as you know, that particularly as adults, how we decided to cope and manage and respond over time becomes habitual and unconscious. And so it becomes more difficult for it to appear uh, to be a simple choice. Even though everything you said is correct and it's consistent with what I said, I'm not disagreeing with you. I am just saying that I think more to even your point that we have to look actively for ways to take back control of things that we may not be consciously choosing, because there's a lot of unconscious decisions being made that are just patterns of our behavior, patterns of our defensive support system, patterns of the way we cope, etc., that we've been doing for years as adults, right? So I agree with you, and I think that this is a important thing to think about by reflecting on what do we really have choices over and what we really don't. And I think if everyone on this call spends a moment after the call, whatever, reflecting on what you really are choosing to do or can choose to do differently versus what you are not, you'll find that, myself included, that we have been giving away, or I should say, not exercising all the power of choice that we actually have. So I appreciate that, Vina, so much. Um, So, Dave, I hope, between Vina and my comment, I hope that we sort of address that probably more than necessary. But I do think it's germane to the bigger and broader question, of life. And I will say that for the most part, the only augmentation I would make to what Vina said is that, pain is inevitable, and maybe a little bit of suffering is inevitable because it's kind of hard to be robotic and turn that off. But this prolonged suffering, is something that you choose. And I'm only saying that facetiously, Vina, because I'm thinking about smashing my finger with a hammer. That pain and suffering is going to last for a little bit. But after a certain point, I certainly make